Doctors. So we're going to continue with the Mrcp Psces 23 consultation station, and today I'm going to discuss a bit about the celiac disease. Um, this case is also quite common in the Mrcp examination, and you may come across this case during your consultation station as well as in your abdominal station. So let's start with our presentation. So first of all, let's talk a bit about history of this patient. So this is a 52-year-old Caucasian woman with a 20-year history of anemia and chronic fatigue, and she is referred to Digestive Health Clinic for further investigation and management. She has experienced multiple episodes of diarrhea, abdominal bloating, and discomfort, in particular after consuming bread and pasta. So the history is quite obvious here actually. Now, celiac disease is actually most commonly diagnosed between the 4th and 6th decade of life. However, symptoms can manifest at any age from infancy to elderly. And there is an increasing frequency of pediatric patients, which may be partly explained by improvement in diagnosis and awareness of this disease. So, like most autoimmune disease, celiac disease is more common in women than men. And there are numerous theories which attribute to this disparity. They say there's some disparity to sex hormones and chromosome. Now, remember, due to non-specific and variable symptoms and signs, celiac disease is often incorrectly diagnosed or underdiagnosed. So other diseases that have similar presentations, they include food intolerance, inflammatory bowel disease, and irritable bowel syndrome. No significant test is available to diagnose celiac disease. Instead, disease diagnosis is dependent on a thorough history, examination, and investigation. Okay, now this lady has a history of anemia and chronic fatigue. Now remember, chronic anemia is a consequence of malabsorption of nutrients. So small bowel inflammation results in mucosal disruption, so limiting the body's ability to absorb nutrients, especially iron, minerals, and vitamins. And these frequent bouts of inflammation eventually lead to villus atrophy, which exacerbates the nutrition deficiency. Remember, chronic fatigue, another common complaint, and this is because of the malabsorption of nutrients. And in the pediatric population, failure to thrive and grow is also observed. She also had multiple episodes of diarrhea, abdominal bloating, and discomfort. Now, diarrhea in celiac disease, it has a secretory and osmotic component. And prolammin antigens in wheat, rye, barley, and other grains, they activate both the innate and adaptive immune systems. So immune cells like dendritic cells and macrophages, they stimulate the intestinal intraepithelial lymphocytes, so augmenting the secretion of inflammatory mediators and cytokines. And this can augment gut motility, leading to secretory diarrhea. In addition to this, the lymphocytes, they also secrete reactive oxygen species and which damage intestinal epithelial cells. And what happened that these immature epithelial cells, then immature epithelial cells replace these damaged cells. But these immature epithelial cells, they lack the brush border enzymes and they poorly absorb nutrients and water. So this is briefly about the pathophysiology of the celiac disease. When you talk about abdominal bloating, it involves some components like subjective sensation of fullness, objective abdominal distension. It's because of the muscular activity of the abdominal wall. And these heterogeneous symptoms is not well understood in celiac disease. However, it is often relieved with restriction of gluten. So she also has recently developed lactose intolerance. Remember, this lactase is a brush border enzyme which is produced by cells in the small bowel. So as villus atrophy occurs, enterocytes, they are unable to produce adequate amounts of these enzymes, so leading to lactose intolerance. So one should be careful to differentiate between celiac disease and other commonly associated conditions like fructose tolerance, sucrose or sorbitol intolerance, and exocrine pancreatic insufficiency. Recent blood tests have also revealed vitamin D and calcium deficiency. Now, dietary vitamin D is absorbed in the intestine, and its absorption is dependent upon the presence of fat in the lumen, and this triggers the release of bile acids and lipase. So, in turn, the bile acids actually initiate the emulsification of lipid. Pancreatic lipase hydrolyzes the triglycerides into monoglycerides and free fatty acids, and the bile acids support the formation of these lipid-containing micelles, which diffuse into enterocytes. Calcium is also absorbed in the proximal part of the small intestine. However, transport is dependent on vitamin D. So what happens in patient with celiac disease? Villus atrophy limits the effective absorption of both vitamin D and calcium, and this can significantly increase the risk of osteopenia or osteoporosis, especially in postmenopausal women. Her past medical history include type 1 diabetes, mellitus, hyperthyroidism, and chronic itchy rashes on her knees and elbows. So there is a genetic association between celiac disease and other autoimmune disease like thyroid disorders and diabetes mellitus. And mechanism that underlie the coexisting of this disease, this can be partially explained by the overexpression of HLA-DQ2 and DQ8 haplotypes in patient. There is also a chronic itchy rash on her elbows and on her knees and elbows, and this is a dermatitis herpetiformis. It's a chronic pruritic skin condition, and it is associated with HLA-DQ2 and HLA-DQ8. And these are papillovesicular rashes. They erupt on the extensor surface of the body, and they are often exacerbated after the ingestion of gluten. And patients who continually scratch these rashes, they increases the risk of secondary skin infection is caused by skin flora. And biopsy of these vesicles reveals immunofluorescent IgA deposits. Family history is significant for celiac disease. So positive family history for celiac disease is strongest risk factor for its development. And I already discussed that several genes have been implicated in its development. So notably, we're talking about HLA-DQ2 and HLA-DQ8. And these two variants have been found in more than 95% of patients with celiac disease. However, the frequency of these genes vary widely, with the highest prevalence of celiac disease in Western Europe. So that's all about the history. Now we move on to the examination of this patient. So this patient has a small body habitus, appears calm, alert, and in no respiratory distress. She is hemodynamically stable and afebrile. Over the extensor surface of her arms and legs are darkened patches of skin with excoriations. So here you can see I have put the picture of the dermatitis herpetiformis, and dermatitis herpetiformis is often exacerbated after the consumption of gluten, and continual scratching of these pruritic rashes can form crusts, excoriations, and skin discoloration. Normally they are in the extensor surface. So peripheral examination is non-specific with brittle nails, conjunctival pallor, and multiple oral aphthous ulcer noted in the inner cheeks. Now remember, the nail changes are common in patients suffering from malabsorption. So we should consider zinc, calcium, or protein deficiency in patients with leukoplakia. Leukoplakia are multiple white spots. Coeliac, these are spoon-shaped nails because of the iron deficiency. Anemia. Horizontal ridging. These are the vertical regions which occur normally with aging, and weak splitting nails. The pathophysiology of recurrent oral aphthous ulcer in celiac disease is unknown, but is most likely related to hematinic deficiency. Abdominal examination is also unremarkable apart from some central tenderness. Now, the inflammation in the small bowel in celiac disease leads to a viscera-somatic response with pain and tenderness felt centrally due to its mid-gut embryonic origin. Bowel sounds are highly active and digital rectal examination was declined. So, highly active bowel sounds, these are known as Bober-Gumming and results from increased peristalsis as a consequence of gluten consumption. And obviously, you're not going to do the digital rectal examination in your MRCP examination. But you can just offer it because no abdominal examination is complete until you've done the digital rectal examination. So this was all about the examination. So mainly going to focus on the rash, and the main focus will be on examination of the abdomen. And obviously, in addition to this general physical examination, because looking for any signs of anemia or any nail changes. Let's move on to the investigations of this patient. So full blood examination we'll go like to do, and we'll expect to see low hemoglobin, low MCV and MCHC. We also want to do iron studies, which will reveal elevated transferrin and total bile capacity with low transferrin saturation and ferritin concentration. So this picture is typical of iron deficiency anemia. And other thing we'll want to look for will be check the calcium level, and we'll expect to see hypocalcemia. Now remember that malabsorption of nutrient, they can result in anemia and is defined as hemoglobin less than 13 in adult males and less than 12 mg per liter in adult females. So remember that when iron is transported around the body, it is bound to a glycoprotein known as transferrin. However, the villus atrophy leads to poor absorption of iron and therefore low transferrin saturation. The body do increase the transferrin production as a compensatory mechanism, and it causes an increased transferrin expression, and this results in corresponding increase in TIBC and low transferrin saturation. And celiac disease is often associated with hypocalcemia due to malabsorption. What other investigations we like to do? We want to do the serology for anti-endomycin antibodies, anti-transglutaminase antibodies, and so these were and total serum immunoglobulin A levels. So these all were elevated. We expect them to be elevated. So serological studies, these are the first line investigations. However, seronegative findings do not rule out celiac disease. Patients must be consuming gluten-rich food as blood tests may normalize on gluten-free diets. So both anti-EMA and anti-TG antibodies, they have similar sensitivities and specificities for celiac disease. However, this anti-EMA is more labor-intensive and costly with greater specificity but lower sensitivity to anti-TG. Endomysium is actually a connective tissue layer that surrounds smooth muscle fibers. So antibodies to EMA are produced in response to gluten-induced intestinal inflammation. Tissue transglutaminase enzymes are found in endomysium that form epitopes when they react with gliadin, and these epitopes are thought to be antigenic and causes gut inflammation. Another important point is total serum IgA, they should be performed in parallel because approximately 5% of patients with celiac disease are deficient in IgA. And this therefore renders anti-TG IgA test unreliable. So in these cases, IgG transglutaminase antibodies is performed instead. So instead of IgA, we would like to do IgG because the patient is already low in IgA. IgG antibodies were not performed, okay, because it was not needed actually. Serum vitamin B12 was reduced. So vitamin B12 deficiency is common in patients with celiac disease due to poor dietary malabsorption This vitamin is absorbed in the terminal ileum, and this segment can be affected by the celiac disease. Thyroid function test revealed an elevated TSH and low T4. Patient immediate family was recommended to undergo gene testing. So there is evidence to suggest that patients with celiac disease, they are predisposed to developing other autoimmune diseases like hypothyroidism. The coexistence of celiac disease and autoimmune thyroid disease is thought to be due to over representation of HLA DQ2 and DQ8 haplotypes. So obviously we want the family members to go for the genetic testing also. So moving on to our investigations, we want to do the imaging. Abdominal X-ray and CT was considered to rule out other pathology. So remember that radiological imaging generally is not required unless to rule out differential diagnosis. But obviously, clinicians should be aware of certain characteristic findings. Small bowel follow through, they may show fewer jejunal folds and increased number of ileal folds, small bowel dilatation, wall thickening, and interception. And extra-intestinal abnormalities, they include mesenteric lymphadenopathy, maybe some vascular changes, and splenic atrophy. So, due to positive IgA result, an OGD was ordered. Now, OGD remains gold standard diagnostic test. If serological tests are positive, then OGD is highly recommended to confirm the diagnosis. If the serological studies are negative but clinical suspicion remain high, then OGD should still be performed. Intraluminal examination in endoscopy revealed scalloping of the small bowel folds, a cracked mud mosaic mucous pattern, and submucosal blood vessel presence. Biopsies taken in 5 different locations noted intraepithelial lymphocytes, villus atrophy, and crypt hyperplasia. Remember that patients, they are advised to remain on a gluten-rich diet prior to endoscopy. Macroscopic examination, although it's not diagnosis, it can demonstrate scalloping of duodenal mucosal folds, a mosaic pattern on the mucosa which leads to a cracked mud appearance, and blood vessel predominance due to increased inflammation. Biopsies, this must be taken from multiple locations as not all areas of intestinal tracts are affected equally. This reduces obviously the risk of false negative. Now I have shown you the slide of the different the histological findings, and this is actually something called Marsh classification, and is commonly used to grade the severity of celiac disease. Crypt hyperplasia actually precedes villus atrophy and involves elongation of the length of the crypts of Lemmerken. Elongation is caused by the expansion of the lamina propria due to inflammatory cell influx, proliferation of stromal cell, and tissue remodeling. So villus atrophy is generally pathognomic for celiac disease with the height 3 times its width. So here you can see in Marsh 1 we have subtotal villus atrophy, Marsh 2 is total villus atrophy. So the Marsh stages start from 0, 1, 2, and for the 3 we have 3A, 3B, and 3C. And 3C is they have very severe villus atrophy and crypt hyperplasia. And the third thing we want to see is intraepithelial lymphocytes per 100 enterocytes, and these are more than 30. So this is all about the investigations of the celiac disease. Remember, we started with a simple blood test, um, rule out any autoimmune disease associated with it, do the imaging, and the final test is obviously the biopsy. Okay, coming to the management. So we'll divide the management into the immediate, short term, and long term. So immediate, the patient advised to immediately cease consumption of gluten. Electrolytes and vitamin supplementation was initiated. So as no medications are available, ceasing gluten consumption is the mainstay therapy. This prevents the intestinal inflammation, allowing the GI tract to heal and eventually resolution of symptoms. Failure to comply can cause a relapse of the disease. So withdrawal of gluten is also used as a diagnostic test in patients who continue to have symptoms despite a gluten-free diet. A careful dietary history should be taken. Symptoms may in fact be due to other disease such as small intestinal bacterial overgrowth, maybe lactose, fructose, sucrose or sorbitol intolerance, maybe because of pancreatic insufficiency and microscopic colitis. So remember that villus atrophy, it prevents the optimal absorption of nutrients, minerals and vitamins. So patient may be required to take dietary supplements, infusions or injections to treat the nutritional deficit. Calcium and vitamin D supplements are recommended in most patients to reduce the risk of osteoporosis. In the short-term management, we can refer the patient to the dietitian specializing in celiac disease. If symptoms persist, steroids may be considered. So dietitians, they can educate and assist patient in choosing gluten-free products. And numerous countries have different guidelines on what are acceptable levels of gluten in gluten-free products. Dietary counseling is also essential as gluten-free diets may be low in fiber, vitamin and nutrients and high in simple carbohydrates and fats. Immunosuppressant, well, they are generally used on an off-label basis if villus atrophy continues to occur despite gluten withdrawal. Steroids are often the first-line pharmacotherapy used. Other immunosuppressive medication prescribed include azathioprine and cyclosporin. And these medications are rarely used as their side effects often outweigh their benefits. So in terms of the long-term management, we'll follow up and continuum of care with a primary care physician is recommended. DEXA scan for patient at risk of osteopenia and osteoporosis should also be considered. Failure to respond to gluten-free diet necessitates referral to a digestive health specialist, and the patient should also be monitored for gastrointestinal T-cell lymphoma. So, a small subset of patients, they may have a refractory disease, which can generally be attributed to poor diet adherence. However, other differentials such as small intestinal bacterial overgrowth, microscopic colitis, or other dietary intolerance should be considered. So referral to a celiac specialist may be necessary for further investigations and management. Finally, a few words about T-cell lymphoma. Enteropathy-associated T-cell lymphoma is a rare complication of celiac disease, so in which T-cell lymphoma develops in areas of small intestine with active inflammation. Etiology is not well understood. When this malignancy is detected, surgery is to prevent spread and reduce the risk of bowel obstruction and perforation. And sometimes adjuvant chemotherapy is also required. So this is all about the management of the celiac disease. Hopefully you find this presentation helpful, and I'll see you in my next presentation. Thanks a lot.